Can assess the importance of treatments with patient-reported outcomes statistically, prove the importance of treatments. We can prove the importance of lifestyle. We can show the importance of socioeconomic background. We can even use patient-reported outcome data as predictors for what will be in 5 or 10 years. So even what we have today is really pretty good. And one of the things, of course, is that we need to have the acceptance of these instruments from the regulators such as the FDA and the EMA. They need to be convinced that these instruments are valid and even better than maybe the classical outcome measures. Just a few of the registries have actually focused on patient-reported outcomes, and more are, so they are gearing up in widening the scope of their data collection by including patient-reported outcomes also. And that's a very welcome development, of course. Hi, I'm Jan Hillert. I'm a neurologist at Karolinska Institute in Stockholm, Sweden.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. In today's episode, we're examining the expanding role of patient-reported outcomes, a critical tool in capturing the lived experience of MS beyond traditional clinical and imaging metrics. As MS research becomes increasingly focused on real-world relevance and individualised care, patient-reported outcomes offer a unique view into symptoms like fatigue, mood, and cognitive change, factors that can sometimes escape objective measurement but profoundly impact quality of life. My guest in this episode, Jan, has been heavily involved in research utilising and investigating the use of patient-reported outcomes. Together, we'll unpack how they are being integrated into clinical trial design and observational studies, discuss current limitations and barriers to their use, and explore best practices for their validation and interpretation. Jan, thanks for joining me.
Very happy to be here.
So I guess as a way of introducing the topic for people who may be completely new to what patient-reported outcomes are, can you tell us really what this term means?
Yeah, so patient-reported outcomes reflects data reported by patients on patients' perception of their functioning in life or their life situation. All kinds of subjective aspects of life which may be affected by a disease such as MS.
And as sort of said in the introduction, this is an area that you've been involved in. Can you tell us a little bit about your work in the space?
Yeah, so I've started and chaired the National MS Registry in Sweden, and we cover some 90% of the patients. And we've been collecting information in a structured way on these patients for over 25 years. And since 15 years, we have included patient-reported outcomes as part of the data collection.
I think it's a good point to talk about registries. They've obviously become incredibly important for observational studies, and we've talked at length in other episodes about the importance of observational studies and how they can tie in and expand on data given from clinical trials. But how important are registries in terms of patient-reported outcomes and their use in research?
Well, not as important as they should be, I think. Patient-reported outcomes, of course, reflect things that clinical outcome measures don't really ideally assess. But when you start clinical registries, of course, you're always based on the notion of clinical information. So they're dominated by the typical clinical outcomes and the doctor's perspective on health and the situation of patients. And I think that so far, just a few of the registries have actually focused on patient-reported outcomes, and more are. So they're gearing up in widening the scope of their data collection by including patient-reported outcomes also, and that's a very welcome development, of course.
So in the Swedish registry, what sort of patient-reported outcomes are you currently collecting?
There are 3 or 4 different ones that we collect very, very regularly. And one is the MSIS 29, which is a 29-item questionnaire which has been developed by Jeremy Hobart in the UK in the early years of this century. And it's well developed. It reflects physical functioning as well as psychological consequences. Then we also have EQ5D, which is a very short, very brief instrument, which is meant to actually be used in socioeconomic studies of finding a value on patient disabilities and functioning. And then we also have a couple of fatigue scales that are used a little bit less consistently. And then we have a symptom inventory, which is more meant to be a clinical tool to make us doctors not forget about important aspects of life, which doctors are typically prone to do.
And so I want to talk about some of the success stories that we've got so far from using these, but maybe before we get there, considering what we're talking about at the moment and mentioning that maybe registries aren't being used as much as they could be to collect this data, what are some of the limitations around this at the moment? What are some of the barriers to being this done more extensively?
Well, one is that we don't have a consensus on which instruments to use, which questionnaires to use. And before we have that, I think that people hesitate in making the effort. It's a big effort to have a complete registry with all the healthcare professionals in the country or in the network to do the same thing, to work in a coordinated way. So consensus is something that would really help. Then we're all aware of limitations of the existing questionnaires. Also, they have some properties that can be questioned. Various dimensions of validity which can be questioned. And do they measure what we believe they measure? Are they collecting data in an analytically ideal way? So how can we deal with them statistically to translate patient experience into something measurable in the end? So those are some of the limitations. Then, of course, if you are to have patients report on something over and over again over a long time, which is what registries are meant for, the long-term perspective, then you need to have something which is not too laborious for patients and something that patients can readily, do without getting fatigued or just frustrated.
So I guess in terms of that, and this is a question coming from me not understanding if there's a distinction, we talk a lot about the use of wearables as potentially collecting data from people and different technology that can incidentally collect data that can be used for research. Would you classify that sort of data as patient-reported outcomes as well?
I wouldn't do that by definition. They are basically, obviously, patient-centered. I mean, they originate from patients. But I think they are a different species in a way. On the other hand, they are then thought to be really good to integrate together with patient-reported outcomes in smartphones, for instance. And there have been a couple of very ambitious projects still ongoing, but the development of those has been quite frustrating. They have not panned out the way people really hope, and I think there is a tendency of hoping too much on IT solutions, on complex things that actually can't really be managed without people really engaging and doing the effort. So consensus is really important. I mean, we desperately need that in order to go out and do this consistently. Many of the instruments also are quite extensive, with lots of items, and patients get fatigued by the test themselves. And then, of course, the way people respond depend on their level of fatigue, the mood they have, the level of pain they have. So there are a lot of biases or factors affecting how people respond to the questions also. So there are also inherent limitations on the quality of the information. Nothing that it couldn't be overcome. I'm sure this will be overcome by designing smarter and less sensitive instruments.
So with the analysis of this data, what are the challenges and how are they being overcome at the moment? Because obviously we have, and as I said, we will talk about some of the success stories out of this, but it obviously is quite different data than people are used to dealing with.
It is different data. On the other hand, I think we shouldn't overemphasize the limitations, because when you have a sizable data set and when you analyze what you have, like we have done quite extensively with MSIS 29, we do get signals. I mean, we see things all over the place. Of course, there's noise, but you shouldn't exaggerate that noise. With better instruments, we will get less noise. We'll hopefully get better reproducibility. We'll hope to get better sensitivity. In our hands, it seems that those instruments are almost as good as classical clinician-based outcome measures such as EDSS. I mean, they give the same kind of information. We can assess the importance of treatments with patient-reported outcomes statistically, prove the importance of treatments. We can prove the importance of lifestyle. We can show the importance of socioeconomic background. We can even use patient-reported outcome data as predictors for what will be in 5 or 10 years. So even what we have today is really pretty good.
You're right then. Let's move on from the limitation aspect and let's talk about what some of the major findings that have come out of studies that have used patient-reported outcomes as part of their results.
I think that the major findings so far has been the understanding of the consequences of MS, not just being something that can be viewed by a doctor, doing the neurological examination, which has been the classical way of looking at the consequence of MS, i.e. the EDSS scale, which is status-based. So that's one thing, the comprehension of all the consequences of MS. Then I think that in principle, the patient-reported outcomes have also helped us to validate the factors, to show the factors that do affect the progression of MS and the course of MS, such as lifestyle, such as treatment, such as socioeconomic, even such as quality of care. Quality of care affects patient-reported outcomes in the end. Then there are a couple of technical things also that have been used in aspects of validating various outcomes against each other, which I think is really important for for us having the tools of assessing the effects of treatments, etc. Those are so far the best outcomes. Patient-reported outcomes have also been used or are being used in randomized clinical trials. In each of the big programs, they have as secondary outcomes 1 or sometimes 2 patient-reported outcomes, or items at least. They are not the primary endpoint, clearly. And the question is really, why are they on the list? I think they should be given more priority. They should be lifted up from, being number 12 on the secondary outcome and secondary endpoint list. But maybe we need better measures, better instruments to really do that.
Do you feel, I guess when this was obviously a topic at ECTRIMS 2024 in Copenhagen, does there feel, from your perspective, an appetite from MS researchers and MS healthcare professionals to start to integrate patient-reported outcomes more in studies?
Not to the extent that I would like to see. I think people are still hesitating. There are a number of ambitious projects ongoing. There is a patient-reported outcome program or project, international, but it's difficult because there are so many instruments out there, and how do we really go about? And I think we need to start actually on the side of developing better tools. People like Jeremy Hobart in the UK, who developed the MSI 29, is very, very much aware of the weaknesses of his own invention. He's trying hard to improve on this. Then there is something completely different, something called the item bank-based outcome measures. Something called the NeuroQual for neurological conditions, PROMIS as a more generic. And this is a set of item banks reflecting all the domains of human existence, more or less. There are like 20 of them. And I think they are designed in a way that make them more analytically ideal, but they haven't really attained the acceptance that I expected when I first heard about it now 15 years ago. And I really don't understand why. And one of the things, of course, is that we need to have the acceptance of these instruments from the regulators, such as the FDA and the EMA. They need to be convinced that these instruments are, valid and even better than maybe the classical outcome measures. And if they are convinced, if they can be convinced, then we will see a big change.
Where do we stand with regulatory agencies at the moment in terms of, you mentioned that they're often included as, low down on secondary outcome measures in clinical trials? How do regulatory agencies view them?
Well, they are still hesitating, and I mean there are efforts trying to provide them with the kind of data they need to accept, but it's to get something approved by such an agency, you need to have the same kind of evidence that you need for a new medicine, for instance. It's a very similar method. So you need very compelling evidence for them to officially, stamp this as a valid outcome measure.
So I guess looking into the future, what role do you see patient-reported outcomes playing in MS research, both in terms of clinical trials, observational studies? Where would you like to see it get to?
I'm convinced that we will overcome the problems we see so far. I mean, we will get better instruments, we will get better consensus, we will get more patient-reported outcomes being collected by the registries, and that's already happening now. And I feel that in observational studies, it would be very clear that this is a really good addition to the information from registries. Regarding the clinical trials, we need to start with the regulators, and then we'll need to have instruments that they can accept from a scientific point of view. So that's probably where it's going, and that will take some time.
In terms of, I guess, collecting these patient-reported outcomes, and you talked about, obviously, the Swedish MS Registry is doing it. I know out of the University of Cambridge, they've got a new sort of registry almost launching called Trusted that's about collecting this data, where the data will be used, or I guess I'm asking you, can the data be used to also help recruitment and selection for clinical trials, to make sure that we're getting the right people picked for the right studies, and also as efficiently as possible by understanding these cohorts better?
It's something that I haven't really thought of, that to use this as a recruitment or a screening procedure for clinical trials, if that's what you're aiming at. I'm sure. I mean, we need to assess. We need to select patients. We need to assess patients, and that goes, of course, both before including as well as during the course of a trial. So that's obviously a way to go.
Look, it's obviously it's a really interesting topic. There's a lot of work that's been done, and some really meaningful impacts that have already come out of this work that you've described. Obviously, we've got a long way to go with it as well in terms of getting it really implemented to the scale that we'd like to see it. But I think people listening to this podcast episode hopefully will gain a greater appreciation for the importance that it can play, and that the barriers that they may be hesitating over, I think you've pretty clearly described that they can be overcome. It's just about approaching them in the right way. So I thank you for sharing all your insights on this topic today, Jan.
Thank you so much for having me. It was a pleasure.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MStranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MStranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grants from Alexion AstraZeneca Rare Disease and Novartis. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.